So I've been asked to talk about patient-reported outcome measures, and in particular in severe asthma, and to pose the question, are the ones that we currently have available fit for practice? But just a little share a little bit of background with you first. As Vanessa said, I'm at the University of Manchester. We're in the northwest of England. And I probably don't need to say too much about Manchester, really, because Vanessa's just back from spending 6 months. I'm sure you're probably all bored to tears of hearing about Manchester. But I will just say that in the 2018 US international rankings for top universities, we came 34th, and we're very proud that the School of Nursing came 3rd, which places us as first in Europe for nursing. So it looks nice and sunny there. This was actually a photo taken by my 9-year-old daughter on Sunday, which was when you were having the heat wave here. I was very silly and went and spent the afternoon down at Newcastle Beach. Made me very poorly that evening, but I have to say it was a delight because this is what I came across. So I don't know if it's a regular sheep walker in Newcastle or if it was a one-off. I don't know. Maybe someone could enlighten me over coffee later on. No one seen her before? My friend said, "You don't see this often, do you?" And she turned around and said, "Well, I do." So anyway, there you go. So what I want to cover in this presentation, a general overview of patient-reported outcome measures, and then start to hone in on the prompts that have been used in asthma, and mostly focusing on health-related quality of life and symptoms, and then asking the question, do we need any new measures that will be specific for severe asthma? And Vanessa, I know what your answer is. And then we'll look at how Vanessa and I are working together to help address what we think the gap is. So there's a whole range of patient-reported measures that are starting to be developed, to be used both in research and to be used in clinical practice. And the one that we're most all familiar with, and I'll assume that everyone here has heard of, is patient-reported outcome measures. So that's when we're focusing on quality of life, symptoms, and other outcomes related to healthcare. Then there's a new stream of reported measures that are coming through that are looking at patient-reported experience measures. So moving away from the old-fashioned satisfaction questionnaires and looking at how we can assess and measure how patients experience not only the healthcare that they receive, but also how they experience living with an illness. Not what the outcome of the illness is, but what's the everyday experience. Needs assessment tools are also on the rise, so looking at not only what the patient outcome is or what their experience is, but taking all of that together, what is their needs and how can we assess that in a robust and rigorous ways. And they're also being developed to assess needs of carers. And then a new one, which I haven't heard of before, I've got experience in developing and validating the first 3, but I've not yet ventured down into the PRAMs, which is the patient-reported attitude measures. So there's quite a lot of measurement going on out there. So these are the different options that we have as healthcare professionals and as researchers when we want to start to measure the impact that we have on patients. And probably the one that a lot of us are most familiar with are process metrics, health and process metrics. So number of exacerbations, death, number of times someone goes to see their GP, number of hospital admissions, normally included in all of the studies that we do. Then we have our objective measures. Of course, we're all familiar with those. Physiological measures, 6-minute walk tests, lung functions. And then over on the other side, we have subjective measures, patient-reported measures. So looking at symptoms and quality of life. And that's what I'm going to focus my talk on. But these are often referred to as soft measures. Very rarely do you see trials that are powered to patient-reported outcome measures, apart from perhaps in the palliative care arena. So we might address some of those questions during my talk today. And then the other question we need to ask is when we're applying questionnaires, and certainly if you're going to set out to develop a questionnaire, are you wanting to develop something that has clinical utility? So you can use it in the clinic, you can use it to track how patients are responding on a day-to-day basis, you can use it to enhance or facilitate shared decision-making. So a patient might complete clinical utility tools on an app and then come into the consultation, and they, rather than you saying, how have you been the last few weeks, they can actually show you a graph of how they've been feeling the last few weeks. Or are you looking to develop something that's specific to research? And we'll touch on this a little bit more. But I think this is probably a situation that we're all familiar with. You give a patient a drug, you treat them, and you say, right, okay, your lung function's improved, you're all fixed now. And they're saying, but I've got the impact of the treatment. I still can't really do everything that I want to do. So what patient-reported outcome measures attempt to do is to capture the patient experience, the patient's perception of the outcome of their health outcomes. Or it might be the reverse in the conversation that we were having this morning, where you give a patient a drug, for example, a macrolide, and the patient says, God, I feel so much better. And you're sitting there thinking, but what precisely is it that's made you feel better? And without the right sensitive patient-reported outcome measures, it's going to be very difficult to quantify that and move from anecdotal evidence into research evidence. And this is what we're trying to do with patient-reported outcome measures. We're trying to move from measuring the objective clinical measurements and moving on to a subjective measurement. And that's actually quite difficult to do. And I'm going to show you a little bit about the process that we have to undertake to do that. But I do think there's a real sea change with patient-reported outcome measures. You very rarely now hear people say that their quality of life is a soft outcome. Indeed, with the patients we deal with, it's a very important outcome. So I've not actually heard PROMs being referred to as a soft outcome for quite a few years now. But the FDA have published guidelines that you should adhere to if you're developing and validating a patient-reported outcome measure. Many PROMs are now registered with the FDA as well as viable outcome measures to use in clinical trials. And certainly in the NHS, in England, we're seeing a real push from the Department of Health to actually start implementing patient-reported outcome measures into clinical practice. So moving from just applying PROMs in the research arena into moving them into the clinical arena. That's a big undertaking. So I'm not going to go through this in any detail, but I just wanted to give you a picture of the process, a very rigorous process and a very lengthy progress that you have to go through to develop a patient-reported outcome measure following the FDA guidelines. And you would start off with the literature review, then you would go right straight to the people who are experiencing the disease or the phenomenon that you're interested in, and you would conduct interviews and focus groups in order to extract items that may then go in to a potential questionnaire. That's the first step. Then you would do cognitive debriefing with people to see that the items that you've pulled out, whether or not they reflect the true meaning with them. You quite often have to change the wording of some of the items so that it makes grammatical sense. We shouldn't be making that decision as clinicians and researchers. We should be checking that we're still remaining true to the original source of that data and including patients in that process. Then you will come up with usually quite a lengthy list for the PROM that I developed in my PhD. Just for dyspnea, for one symptom, I had 81 items that I took forward to the item reduction process, asked about 300 people to complete that questionnaire. Then we ran a series of psychometric tests on that data so that we could identify which items have the best measurement properties in order to include into the final questionnaire. And we ended up with 12. And I was disappointed with that because I thought, gosh, all this hard work. I've had 81 items. It's taken me months to analyze the data. and I've got 12 items to show for all of that hard work. But Paul Jones was my PhD supervisor, so I learned from the best. He developed the St. George's Respiratory Questionnaire, and he kept trying to get me to go down even further, but we stopped at 12. I won that particular argument. And then you go on to doing further reliability and validity testing, and then the questionnaire needs to be tested in a population different to the population that you developed the questionnaire in. So it can take a couple of years to go through this process rigorously. So I think gone are the days when clinicians would sit around the table and write down on a piece of paper what they thought was important to the patients and what they think we should be looking at. There's a whole scientific process behind the development now. So if we just look at health-related quality of life, it's a term that we use in conversations all the time. We use it when we talk to our patients, but it's very complex. There are so many variables involved in health-related quality of life. So it can make it quite difficult for one questionnaire to cover all of these different variables. Not all of them may be related to every different disease group, but it can make questionnaires quite lengthy. And if we're wanting to move towards having less items but keeping precision with a measurement tool, then sometimes some difficult decisions need to be made as to what area you might focus on. Or you develop a very comprehensive questionnaire that can cover all of these different domains, but it may not have clinical utility, but might work very well in a research context. So these are the type of discussions that Vanessa and I are having at the moment with the work that we're doing. And then, of course, we have different types of measures. We can have generic quality of life questionnaires, such as the SF36, the EQ5D, which has been developed to be used in normal populations as well as healthcare populations. And they're really useful because you can compare quality of life of a group of people with a particular condition against population norms, and that can provide some powerful information. Then we have condition or organ-specific questionnaires or symptom-specific questionnaires, such as the St. George's Respiratory Questionnaire, which is a general questionnaire that has been used in many different respiratory populations. Or we move on to disease-specific questionnaires, which are very specific, very sensitive to a particular disease group, such as severe asthma. But regardless of which approach you take there, a health-related quality of life PROM should inform you whether the treatment is worthwhile from the perspective of the patient, not from our perspective or from the perspective of lab results, but how has that treatment impacted on the patient's perception of their own health. And also provide information about illness trajectory from the patient's perspective. So how things change, whether they get better or get worse over time. So really this perspective should include not only the burden of the disease, but also the burden or the impact of the treatments that we prescribe. So where are we at with severe asthma? Well, this is a list. I haven't done a systematic review here, but from my knowledge, these are the different questionnaires, generic questionnaires, respiratory questionnaires, asthma-specific questionnaires that have been used in the severe asthma population. The reason why the column for severe asthma is left blank is because, as far as I know, not a single patient-reported outcome measure has been developed from the ground specifically with patients with severe asthma to be used in patients with severe asthma. So many of these questionnaires have proven to be responsive for patients with severe asthma, but does that really make them necessarily fit for purpose? Are we missing some aspect of experience of severe asthma that isn't picked up in these other questionnaires, even though we can get a signal from them in clinical trials. So these are the questions we need to ask ourselves as to whether or not we need to develop a new PROM for severe asthma. Does impaired quality of life in asthma vary only in severity? So if it only differs due to the severity of the asthma, whether it be mild, moderate or severe, as long as you apply good psychometric approaches when you're developing a questionnaire on asthma severity, and you get rid of your floor effect items and you get rid of your ceiling effect items, then you should get a measure that actually covers severity across all of those three different groups. And that's what the current asthma questionnaires do achieve. But do severe asthma patients have uniquely different types of health-related quality of life deficits that require assessment? So are they experiencing something different to what the mild and moderate patients are? Are items that are relevant to severe patients therefore excluded from current scales that are used in asthma? So we'll see if we can answer those questions in the next 20 minutes. I think it's fair to say that all published asthma-specific health-related quality of life questionnaires do contain items that are relevant to the burden of asthma, whether it's mild, moderate or severe. Some of them also include items relating to the impact of treatment. But what's different about the severe asthma group? And most of the focus has been on the difference between treatment in mild and moderate asthma patients with inhaled corticosteroids and bronchodilators, where you do normally get good control, compared to severe asthma patients who are largely prescribed oral corticosteroids. And that seems to be in the literature at the moment where the current debate is that the quality of life questionnaires that are currently available aren't addressing the specific outcomes of patients who are on oral corticosteroids. That seems to be where the biggest gap is, but there may be other gaps, especially based on our conversation this morning. So I think we all know this. Oral corticosteroids have a direct effect on mood, depression, suicidal ideas, and anxiety. We know that. But are we tapping in to these symptoms in a sensitive way for severe asthma patients in the current tools that we are applying? And of course, there's physical effects as well, which also can go on to have a psychological implications for severe asthma patients. So I'm going to present now a really interesting paper that was done by the Southampton group in the UK, Hayland et al. And what they did, I wish we'd thought of this, but what they did was that they interviewed 23 patients with severe asthma to really get an idea as to what their experience was of living with asthma, but more pertinently, to go in and ask patients about the treatments that they were receiving and the impact that the side effects of those treatments was having on their quality of life. And what they found was that the impact of asthma, everyone spoke about activity limitations and emotional impact, not that different to what mild and moderate patients would say, but hospitalizations was a key part of these interviews, which isn't currently captured in currently available questionnaires. And then when they moved on to the impact of medications, mostly on oral corticosteroids patients were talking about, you can see the variety of side effects that patients were describing. Are current asthma tools or other respiratory quality of life questionnaires covering all of these variables that patients with severe asthma were vividly describing in their interviews. Well, this is a summary table pulled from their paper. So we have the different items or domains that patients were talking about in those interviews, then the number of patients in those interviews that mentioned that particular item, and then a summary of the main questionnaires used in severe asthma patients and how many times those items occur in the different questionnaires. So you can see we do have some gaps there, don't we? Very few questionnaires are tapping into a lot of issues that patients were describing in these in-depth interviews. So, thanks to Vanessa for this slide. So Vanessa and I seem to be flying the airways from the UK to Manchester. That's us there, the tiny two little dots there in that picture on the left-hand side when Vanessa was in Manchester, and now here I am in Newcastle, because we're in the process now of the very early stages of that diagram I showed you of developing a patient-reported outcome measure for severe asthma. So we've conducted the interviews both in the UK and here in Australia, and we're just in the process of combining those data and analysing the data at the moment. So what our aim is to develop a patient-reported outcome measure in severe asthma that specifically taps into the quality of life issues that are relevant to people with severe asthma. We're very much following the FDA guidelines for the development of patient-reported outcome measures. But what we're not 100% sure on yet is exactly what that outcome measure might actually tap into, and whether or not we do indeed need to develop more than one type of measure. Is there something about general health-related quality of life, but do we also need to tap into specific symptoms? We're still having those discussions. But we've done some preliminary analysis, or Fiona has here, and some very interesting results are starting to come out. This is just the Newcastle group at the moment, where 10 patients were interviewed and a focus group of 4 people was conducted. And the data that's been extracted to date is focusing on how patients are describing exacerbations. And you can see there that there's a whole range of domains that people are talking about when they're describing their experience of having an exacerbation. So there's almost as many domains there for one part of life in the person with severe asthma and exacerbation compared to the whole health-related quality of life diagram that I showed earlier. So it's a very complex phenomenon, having an exacerbation. It includes social context, symptoms, the lead up to having an exacerbation, the terminology that people use to describe that experience, the associated fear, how they recover, the management, and the unpredictability of the exacerbation. And then we've gone in to have a look at specifically the terminology that people use. Really interesting, 42 spontaneous quotes were describing exacerbations. 93% of those people were using the word attack. Very few used the word flare-up, and very few used the word exacerbation, which is the words that we always use when we're talking about exacerbations. And you can see here that 9 out of 10 patients from the interviews described attack rather than exacerbation or flare-up. And a poster is being presented in Adelaide next week to present these data. So maybe there is something different about severe asthma patients that we're not tapping into yet with the currently available questionnaires that we use. There are similarities, but there also appears to be distinct differences in the experience of severe asthma. And I'm sure all of you in this room know that already, but it's presenting the evidence to support the development of yet another PROM. And this is just showing you some of the quotes to support what I've just said. So people were saying, it's an attack on your life. Another person said that they actually took offence that the term exacerbation was being used to describe the reason for their hospitalisation. So that's pretty strong opinions. It's an attack when it's completely out of control. A flare-up was more a non-serious event, whereas attack was really what patients were focusing on as a serious event associated with severe asthma. So what are our next steps? Well, we're still completing item extraction. I think you've got 2,000 items in an Excel spreadsheet. So somehow or other, we need to try and get that down to, I don't know, 12 items. We're having lots of discussions about how we actually manage to do that. And we still need to decide on the concepts that we want to capture. It's very complex. So we're still having those discussions, and we're going to have to go back to patients to get their views and their opinions on that as well, because it shouldn't be us deciding that sitting around a table. Possibly we need to develop more than one measure. There's over 2,000 items in there. Once we make those decisions, we'll be able to put a grant together to then be able to move on to the next stage of that FDA process. So watch this space. Hopefully we'll be able to secure further funding to complete that process. But the other question or conversation we've been having is, are we wanting to develop something that also has clinical utility? So do we also want to develop a questionnaire that, yes, can be used in clinical trials, but actually patients can complete it when they're in the waiting room and can share those results with the clinician, which could help to guide shared decision-making processes. And when we think of clinical utility with questionnaires, less is more, but you still need to have good measurement properties so that you're not losing any sensitivity to picking up any change. And I'm sure you're all familiar with the St. George's questionnaire, as I said, developed by Paul Jones at St. George's. It has 50 items, and this questionnaire has pretty much been the mainstay of measuring health-related quality of life in many different respiratory diseases, even diseases that when Paul developed the questionnaire, he would never have thought that it would be used in, for example, pulmonary fibrosis. But then he moved on to developing the CAT assessment test, which more or less does the same thing, but it does it in 8 items, so 42 less items. So is the CAT as comprehensive as the SGRQ? Well, you can look at the size difference and say, no, it's not, but is it as effective in measuring health-related quality of life in people with COPD? They have a correlation of 0.8. So maybe less is best, because the CAT is actually being used in the NHS for clinical audits, as well as in clinical practice, as well as in research studies. So we need to have a think about what our questionnaire or questionnaires may also look like, and if we also want to go for that clinical utility, which I think is very important. What about symptoms in severe asthma? This is a list of the main symptoms that were being mentioned. Are there any questionnaires that have been developed in severe asthma to focus on symptoms? And the answer again is no. But what is it about the symptoms in severe asthma that we might want to know? Is it the sensation that people have? Is it the impact? Is it the physical or emotional consequences of that particular symptom? Is it how the symptom affects activity limitation? Or are we interested in, well, we may not be able to change the severity of the symptom, but maybe we could look at interventions to help patients better manage and increase their self-efficacy. So are we interested in looking at symptoms, but more from a coping perspective? And then, of course, there's questions, well, what is it we want to know? Is it the severity of the symptom or how often that symptom occurs? Is it having the symptom now or today? Or is it in the past week? Or is it in the past 2 weeks? And to me, with questionnaire design, these types of questions are the elephant in the room. We all talk about how we generate the items and the psychometric tests we apply, but the other decisions about whether you're looking at severity, frequency, the scaling options that you have for individual items, should you have a middle point, should you not? Should it be frequency along a severity scale? They're not normally discussed all that well in publications. So we don't always know if those decisions have been made in collaboration with patients or not. But one questionnaire that has been used in severe asthma patients were included in its development. And we have gone on to use this questionnaire, the Dyspnea 12, in a trial of CBT specific for patients with severe asthma. So it's a simple questionnaire. It scores from 0 to 36. It also has 2 subdomains. The first 7 items focus on the physical sensation of breathlessness, and the last 5 items focus on the emotional impact. Now, really interesting, in the CBT study that we did in severe asthma patients, we found that we got the biggest signal not in the physical sensations, but in the emotional sensations. So moving forward, we also included the Juniper quality of life questionnaire as well, and the HADS questionnaire, but we didn't get a very big signal from those questionnaires. We got the biggest signal from the breathlessness questionnaire, but mostly the emotional component. So we said if we went on to do the fully powered trial, which we haven't, that we would power to the Dyspnea 12, in particular the affective domain. And in the interviews with patients after the trial had finished, they were telling us it was the anxiety related to breathlessness that the intervention helped them to manage. So perhaps symptom-specific scales in severe asthma are also important. But remember, this scale was not developed including severe asthma patients, but we went on to do further validation studies in severe asthma after. And just to show you the difference here, again, going back to my elephant in the room about how we present questionnaires, we weren't sure when we developed the questionnaire whether we wanted to focus on a general these days, how is your breathlessness, or right now and today. So we presented patients with both options, but in random order. And you can see that consistently we have COPD, ILD, and asthma patients in this, not severe asthma patients, that when patients were responding to these days, they constantly scored higher on that breathlessness scale than how they felt today. Many reasons for that, we don't know. This is hypothesis generating, it's very exploratory, but they completed the questionnaire when they were turning up for a consultation at the clinic. So it may be they were on a good day that day because they had turned up to the clinic. We don't know the reason behind that. But what we did find interesting is that between these days and today, we found the biggest variation in the COPD population, whereas we thought we would find the biggest variation in the asthma population. And again, we don't really know the reason why we found these results. So you may think that existing asthma proms may be providing an overly positive estimation of health-related quality of life in patients with severe asthma. I think going back to that table that I showed, there is evidence that the currently available tools do not tap into some key symptoms, mostly related to treatment effects, that patients with severe asthma experience. And there's a lack of assessment of specific symptoms. So I'm going to conclude by posing the question back to you. Are current PROMs used in severe asthma fit for purpose? Should Vanessa and I stop flying across the airways, stay home, or should we keep doing that? Thank you.
Thanks, Janelle, for an excellent presentation. And I suggest the answer is no, we shouldn't stop. I'll open the presentation for questions. Just check with Steve to see if there's any online questions coming in. No, so we'll go to the audience. Are there any questions out there regarding? So do you think that people that have been used to using PROMs in severe asthma, do you think that the current PROMs that we're using are measuring what we want them to measure?
Head shaking. Anyone nodding?
Okay, so we're on the right track.
Yay, see you next year.
I think if you look at the improvements we've seen with some of the biologics in terms of exacerbations, and then the quality of life has just been left behind. It hasn't produced the signal that we're seeing clinically. The patients come back and feel great, but it's not being picked up by the current questionnaires we have.
Yeah, and we certainly saw that in the CBT study.
So I'll just repeat what Tim Harrison said for the online audience, in that comparing what we're seeing in the trials of biological therapies,
and individual experience.
And individual experience, and seeing that we're not seeing the signals with the symptom measures and the quality of life measures that we would really kind of anticipate when you actually look at how the patient's feeling in response to that therapy. Yeah, for our current PROMs.
So, what do you think then are the key areas that are being missed? I mean, I've presented mostly because that's what's in the literature is patients, that the impact of oral corticosteroids. But is it just about that? Is that all we're missing in these tools? Do we just need to add in a subdomain to the questionnaires that are already available? Or
I also wonder if we're missing the exacerbation events in current quality of life questionnaires. So, as we were discussing earlier, an event that's happening 3 or 4 times a year, it's quite a major effect on someone's life, but I'm not sure whether it's being captured, and therefore, if you take those exacerbations down by 50%, is that being picked up by current questionnaires? Would be another area I wonder.
So again, Tim's questioning whether the current questionnaires are capturing the exacerbations that people are experiencing with severe asthma, and the frequency of those exacerbations and reduction following new therapies and treatment.
So if we, hypothetically, if we developed a questionnaire specific to severe asthma that was focusing on the experience of exacerbation or as health-related quality of life for severe asthma, would you be tempted to use a PROM as a primary outcome measure for some of these clinical trials rather than exacerbation? You'd probably need less numbers of patients.
I wouldn't at the moment, so I don't think we've got one.
Yes.
But if we developed one, yes.
Okay. Okay.
Peter Gibson.
So if we just take that a little bit further, Janelle, if the PROM is the primary outcome, are people going to accept that as high quality evidence. So the experiences I've had as you focus in on the sorts of outcomes that your treatment is delivering, you often come up against a barrier where someone will say, okay, what about cost effectiveness? So you're using a disease-specific questionnaire. How do you translate that into dollar benefit? What's your response to that as a limitation of this approach?
So I think if I summarise Peter's question, it's around, are PROMs hard enough outcomes to satisfy people in terms of believing the data, in terms of the impact that they have, and to convince a health economist.
Yeah. So we need to look at bringing a health economist on the team, and we need to maybe look at developing a tool that also has economic utility as well. So similar to the EQ5D. Now that's a process that I don't have experience in, but I know we've had conversations about that before. But
are there examples of PROMs that have done that?
And the EQ5D, but that's a generic PROM, so it wouldn't be sensitive enough, which you probably include as a secondary outcome in a lot of your studies to do health economics, but and to work out QALYs, but you probably wouldn't have that as a primary outcome measure in a severe asthma trial because it wouldn't be sensitive enough. And it kind of defeats everything that I've just presented.
But to answer Peter's question, it is used a lot to assess the cost effectiveness of a treatment. Other things are translated into EQ5 to give us the QALYs.
Yeah.
So I can't see why not.
So you could use the EQ5D absolutely to do that, or we look at developing something where we can feed those same things into our questionnaire. Absolutely.
Peter Yorke, so are you hoping that the PROM will replace measuring exacerbations? Is it going to be possible to have a PROM that will take the impact of an event, which is often distant in time to when you're going to measure it, such as an exacerbation? Or do our current tools poorly reflect patient experience in terms of symptoms in the severe asthma field? I guess they're all really three components of what you're asking.
Yeah.
So Peter Yorke's asking, are we expecting that a PROM will replace the measurement of exacerbations? And do we think that the current questionnaires are not measuring the symptoms?
I mean, is it possible to get a PROM to really reflect an exacerbation? We know these are bad things on many levels. They cost money, they're horrible events for the individual, some people die, they've all got very bad outcomes. But assessing a change which removes or reduces exacerbations may be very, very hard to do, particularly if, as has already been mentioned, you only have, say, 2 or 3 a year. It can be hard to capture that in a single second.
So no, I wouldn't suggest that a PROM on exacerbations or general health-related quality of life in severe asthma replaces collecting the number of exacerbations. No. Could it replace lung function? Well, if I want to play devil's advocate, maybe, because we know there's a poor correlation between lung function and how people perceive their own respiratory health. So, I don't know, maybe. I can see Peter grinning over there. But what was the second question, sorry?
The second part is many of our current PROMs really focus on symptoms.
Yeah.
But they're probably very poorly represented the severe asthma symptomatology.
Yeah, absolutely. Yeah, and I think that the previous slide showed that very clearly. There's a wide range of symptoms that people with severe asthma experience, and really we only ever tap into breathlessness and cough, and we don't do that very well. So I will stand by saying that there is, regardless of whether it's quality of life or symptomatology, no currently available questionnaire has ever been developed from the ground with people with severe asthma. So in a way, many of the questions that you're asking, we're not actually quite sure yet. You know, we've got over 2,000 items that we've pulled out, but we're still not quite sure what domains or what concepts we're really going to be tapping into yet.
I might also add that we've not only done the interviews in severe asthma population, but have also done the interviews in a mild to moderate population. So we'll actually be able to look at, are those items different across the groups, and not only just make those assumptions that they are.
Yeah, so although the Heyman paper does actually go some way to tell us that the questionnaires that have been developed in the mild and moderate asthma population miss many, many symptoms that patients with severe asthma are describing in interviews. So in a way, that's looking at it retrospectively, whereas what we're doing is actually we'll have the mild to moderate data and we'll have the severe asthma data, and we'll be able to do direct comparisons, which hasn't been done yet. So again, that will go some way to answering your question about the exacerbation experience and symptomatology as well.
Steve?
I'll just come closer so we don't have to repeat. So there was a couple of questions online, a couple of comments that fit into the same trend of areas that aren't collected by the current measure. So one is chronicity of disease.
Yeah.
One is the effect on family, especially in the pediatric population.
Yeah.
So
yeah, absolutely. Massive gap. I agree completely.
And I guess the other one is a question of, so what are we already doing in severe asthma clinics to meet the needs of individuals with severe asthma that's different from mild to moderate asthma? And can that also serve as kind of material to capture, to show the difference?
You might be best at answering that, Vanessa. I don't do severe asthma clinics.
So I guess overall the approach is different in that we, firstly identify what the comorbidities and the aggravating factors are that are related to the severe asthma, and then look at more therapies that are targeted toward those interventions. I mean, that's also the case somewhat in mild to moderate disease, but these comorbidities and aggravating factors are far more prevalent in a more difficult to treat population than they are the mild to moderate population. But I think overall there probably isn't enough support for those severe asthma clinics to be able to deliver that approach as well. So so there are differences in the approach to treatment, but they're not highly supported, I think.
Okay.
Peter?
Seems, Janelle, when you're describing the data that you're collecting, that patients could be ambivalent about what's happening to them. On the one hand, they might fear the severity of the exacerbation, but on the other hand, they don't want to take the treatment of oral corticosteroids, which will prevent the exacerbation. So is that ambivalence, does that come out, or can it be brought out in this process?
Yeah, so that's like Fiona screwing her face up there. Yeah. Oh, Kim, sorry, Kim. I do apologise, Kim. That's why she's screwing her face up at me.
Yes. We simply get the name right.
Sorry, Kim. So Kim's read all of the interviews and is probably best to answer that particular question. But I think that's such a complex area in looking at why people do or do not take medicines as prescribed. And we know in the general chronic condition literature that 100% adherence is only about 50% anyway. And we even found that in the pulmonary hypertension population, you know, a life-limiting condition, that it's 100% adherence is about 50%. However, most of that is actually non-intentional. So people forget to take their drugs. They have busy lives, children to get to school, work to attend to. So not all of it is actually intentional. But I think this is where shared decision making becomes so important in severe asthma in particular, where it's a shared decision as to what treatments patients and the clinician agree on being part of the management process, and having honest conversations about medication adherence, and that should be assessed at every consultation as well. I don't know if that answers your question or not, Peter, but if it's being drawn out of the interviews, Kim may be able to shed further light.
I think mainly in the interviews what's coming out is people with quite severe asthma aren't missing their medication. Their adherence is quite high, but they are expressing a lot of distress about the effects the medication are having on them.
I might give one example from the focus group, which was an interesting dynamic because it's a couple of people in the room versus a one-on-one interview. So you get the responses of the other people judging the people that are making the comments. And there was one youngish woman, she's about my age, who had severe asthma, frequent exacerbations, frequent hospitalizations for her asthma. But she openly said, you know, I have days where I just want to feel normal and I don't want to take the drugs, and really that's more important to me than actually whether I end up in hospital, because for that day I feel normal. So she's intentionally making a decision not to take treatment, knowing the consequences of what might happen, but it kind of makes her life normal, and that's what she chooses to do. The other people in the focus group were outraged that she would make that decision about her treatment.
So I had one young lady in my group as well who described exactly the same thing and was on IV therapy and thought, you know what, I feel really good. I wonder what will happen if I stop it. And I think we can all guess what happened. And the other people in the focus group, were outraged that actually this woman, is that fire alarm? No. That this lady would take that kind of risk. It's a really interesting dynamic. Maybe we need an adherence scale for severe asthma. I don't know. You just keep going and going, can't you?
Well, I don't think you've said that you will be able to address the adherence in the problem.
Yeah. Probably not.
And I think what you need to print patient-reported intervention measure.
Oh, I love it.
because now we have the opportunity, to stop the need for oral steroids and to address adherence by directly observed therapy and injecting monoclonals. So I think we're at a point in time where if ambivalence is a real issue, it's worth measuring because we have the opportunity to intervene and change it.
Yes. Okay. So I'll add PRIM to that list just after PRAM. Thank you.
I think picking up on Kim's point as well, it's also interesting because she said most of them said that they do take their treatment religiously, and but again, this is in a fairly subjective interview setting again, and we know that subjective report around adherence is pretty crap, really.
I think it is in an interview process, but if you ask people to complete validated adherence questionnaires, they actually, the way that the questions are worded is so clever that people do actually respond honestly, or maybe slightly overestimate their adherence, but you do pick up non-adherence, whereas if you're interviewing someone, they're probably less likely to disclose non-adherence for whatever the reason might be.
Steve, there's another question online.
So there was a question of, do you think that there's going to be a difference in responses or the need for the question design between people or patients with true severe treatment refractory asthma versus patients that have difficult to treat asthma? symptoms and oral steroids is often similar.
I'm looking at you again, Kim. I don't know if that's coming out of the have we looked that closely yet
No.
at the data? No. But it may very well be the case. There's bound to be generic issues that we can tap into, but there may very well be quite distinct ones as well. Thank you.
All right, well, I think we'll wrap up there because our next speaker is due to commence at 1 o'clock. Now, so I'll just ask you to join me in thanking Janelle. And I'll look